Hi, everybody, and welcome to day 2 of our back to school conference. My name is Megan Carmelani, and I am the founder of Long COVID Families. We are a grassroots, patient-led nonprofit with the mission to support long COVID kids and their families. The theme of our conference this year is to raise awareness about long COVID in children, as well as sickness prevention. We have a great agenda for you today. We're really excited. Dr. Yonts has joined us. She's the director of Children's National PostCovid Program Clinic and is here for a Q&A session with us today. Next, we will share with you an interview I did with a mom of a toddler with long COVID, which we're calling Discover Long COVID Kids, a Toddler's Journey. Then we have 2 brief but compelling presentations that were not advertised. One is a video of 2 long COVID kids telling their story in their own words. And that will be followed by a presentation by Melissa Ramirez, PhD, school psychologist, who will talk about the impact of long COVID on learning. And finally, we will end with a Q&A session with Fran Gilmore, who's here to answer all of our school ventilation questions. So before we begin, a quick disclaimer: none of the information provided during the conference is intended to diagnose, treat, cure, prevent any disease, nor is it intended as medical advice. Okay, so let's get started. We're so glad you're here with us. And let me first introduce you to Amy Torres-Best. She's a parent of a long COVID child and tonight's moderator for our first Q&A. So with that, I'll pass it over to Amy.
Thank you, Megan.
Hi, Amy. So nice to meet you.
Nice to meet you too. All right, well, let us start. How would you define long COVID?
So I think this is one of the biggest questions in this area, and it has definitely evolved over time. So personally, I think it's important to highlight a couple aspects when we're talking about like what is long COVID versus other post-COVID conditions. For me, it has to do with the timing and sort of association and timeline since infection with SARS-CoV-2 or COVID-19. And then the other big piece is symptoms that impact the daily activities or livelihoods of those that are affected. So for those reasons, the definition, consensus definition that the WHO has come up with, published earlier this year, that highlights long COVID in kids. This is pediatric specific, so yay for that. Includes, I think, 2 months of symptoms that have occurred within 3 months of a known or suspected COVID-19 diagnosis that can relapse, sort of flux, go in and out, either that started with the initial illness or came on within that 3-month time frame, and that impact daily activities and daily life, and that don't have a clear alternate explanation, although that doesn't have to be an exhaustive investigation for that. So I think, there are certainly things that happen after illnesses. A lot of us get cough that lingers after any illness. But if it's, something that you can tolerate, that's not bothering your day-to-day life, that's not waking you up in the middle of the night, I think that that's important, but not from a clinical, here's where our resources are needed and trying to define a community perspective. So really the things that are keeping kids from going to school, keeping them from doing their activities, participating as they normally would. Kids being kids.
Absolutely. All right. And based on your observations in your clinic, how does long COVID manifest in children?
So far and away, fatigue is the most common complaint from children that come to our clinic, or symptom, I guess. Complaint's a little bit of a loaded word, I suppose, in some areas. Most presenting symptom, not to use medical jargon. And then following that, I would say almost everyone has fatigue. Following that, we see a lot of kids that also have some ability of difficulty tolerating exercise. And that falls into kind of 2 buckets. Sometimes that's sort of limited endurance and limited tolerability of like in the moment exercise, but also includes those with sort of postexertional symptom exacerbation. So those that, after activity have worsening of their symptoms. on our questionnaire, right as it stands right now, it kind of captures both, but that's something we will hope to refine going forward. We also have a lot of kids that have headache and gastrointestinal symptoms, lots of nausea, sometimes abdominal pain, diarrhea, and then a fair amount that have either new onset or worsening of pre-existing anxiety, typically around their symptoms and dealing with their illness and sort of what's happened as a result of that. Although occasionally, as I mentioned, it's something that exists for that patient before, but has been worsened. So sort of in my like gestalt between looking at the definition, looking at the literature on this subject, and what we've seen in our clinic, which by the way, we've seen, I think now we're up to like 220 children over the past 2 years. So that's kind of our sample size for what it's worth. I would say fatigue plus either anxiety and or post-exertional malaise, and then any of an additional, 3 to 20 other symptoms makes up our typical sort of patient.
Yes, there seems to be a lot of a lot of breath there.
Sorry, but I think really having that fatigue aspect is a very key part to what I would call the syndromic post-COVID diagnosis or syndromic long COVID. And then from there it can kind of go a bunch of different places.
All right, great. If you were in a position to tell pediatricians 3 things about long COVID, what would you want them to know?
So the first thing is that it definitely happens in children, and that any child that has has COVID should be screened for long COVID or persistent symptoms. And that can be as much as just, a phone call, a check-in a month after, just to see if there's still symptoms going on. But I think as of right now, while we have risk factors, it could also happen to anyone. So this could happen to any kid with COVID. So keep your mind available. The second thing I would say, and this is sort of a broader to a lot of different post-infectious or chronic or infection-associated chronic illnesses, is to know what post-exertional symptom exacerbation or post-exertional malaise is, know how to screen for it, and know how to not deal with it. In particular, knowing that there is a risk of worsening patient symptoms by pushing them into more activity and more intense, mental, emotional, physical action before they have improvement of their other symptoms can be harmful, which is a concept that is really absent in most of our medical education and something that's counterintuitive in a lot of ways. So I think having pediatricians screen for that is a really helpful tool. And I've started to get the word out about different screening questionnaires, but even just major questions like, if your kid goes to school, will they be able to go to school the next day? Or will they be able to, participate in sports? How does that affect them? Is it unusually, prolonged fatigue compared to what you would expect? Those sorts of things. And then for my third point, I think it's a little more clinician specific. And this maybe shows a little bit of insight on my own part and having talked with a lot of other clinicians in this area. But I think it's having the humility to accept that there are things we don't know, and to not take that as a fact that we are failing families or patients, or that we are, not helpful in some way, but that we need to grow and work together with families that are going through this to learn about patients, to learn about this condition and other similar conditions, and to, not become so uncomfortable with the unknown and not having a lot of tools to, treat or cure. And just be willing to build a partnership. Because I think a lot of physicians, if we don't know what it is, historically, we've said, well, it must not exist, so we're going to ignore it, which is a terrible way, but it's a way of dealing with that sort of cognitive dissonance of like not knowing what to say, so we're just going to avoid it. And that I'd like to see that change. But it's, we all probably need some counseling and therapy around it and help in our own, roles, and sort of redefining how we, the patient, family, clinician relationship. So sorry, that was kind of a long worded statement, but I think in summary, screen kids with COVID, screen for post-exertional symptom exacerbation, and clinician humility are in bullet points, my big 3 take homes.
That is something that, we have many audiences viewing this conference. So, we want to address what, people are going through, but also what pediatricians can do. So that is really, I think, helpful, because our next question from our community was, what does your clinic do to educate families on post-exertional malaise, otherwise known as PEM?
Yeah, and that's been the terminology that's been used for years, but I like the broader post-exertional symptom exacerbation because it's not always malaise or, which has some negative connotations behind it. Some people just picture lazy, sitting on a couch, fanning themselves. I think it's fatigue in and of itself, but also some individuals can have exacerbation of other symptoms. That may be headache, for example, is a common one we see, or nausea that gets significantly worse after some exertion. So I think the PESE, which is a little harder to get under the tongue, is a better terminology. But the big thing to focus on that, and I have all due credit to our clinic physical medicine and rehabilitation specialist, Dr. Justin Burton, is pacing, and sort of what he, has followed and describes to them as the 4 Ps. So really how to conserve energy and use it in a way that still enables the patient to accomplish some things in their day, to feel like they're moving forward, but doesn't set them backward. And that's a really hard concept for particularly kids to understand, because one of the brilliant things about being a pediatrician is that kids are so resilient, and the second they feel a little bit better, they're back to playing. But that's actually not what should be happening for a lot of these kids. So trying to get the kids to understand that, trying to get the parents to, understand that and figure out how best to manage that with them, is one of the big things that we do in our clinic with our families. And every family sees our PM&R specialist for that reason.
Right. Switching topics a little, are you aware of any more effective vaccines, treatments, medicine, etc. on the horizon? Can we look forward to anything that will help prevent long COVID symptoms in kids or help long COVID kids manage their symptoms in the meantime?
So I am hopeful that there will be treatments. There will be better symptom management, and that there will be actual treatments for some of the underlying pathophysiologic mechanisms that have been explored and identified in research rather robustly over the last 2 years. I think in terms of effective, it's interesting that that's the word that you're using, because that would really imply good research, good study on that to determine effectiveness, to say, yes, this is working better than doing nothing, or working then better than giving a placebo. So I think that is unfortunately still lagging behind. To my knowledge, right now, there is one interventional clinical trial of a medicine called lorazepam at Boston Children's, up in Massachusetts. And that's for, I think, only 7 and older, 10 and older. It's a subset of the pediatric population, but to my knowledge, that's the only active clinical trial that's involving kids. Now, there's a whole smattering that just started up in the adult population, for multiple different drugs, looking at a longer course of Paxlovid, looking at multiple other things. But I think this touches on a question that comes later, is why don't we start these in kids first? And I think anything that's, a novel therapy, especially, but even for things that are being used in a novel way, I think, for better or worse, And some of this is reactionary to historical research, bad deeds. We really, really protect those that we consider vulnerable populations. And children are, chief among those, but also pregnant women, prisoners, anyone who we don't feel like has, as a research community, full say in what's happening to them. And children 7 and older can give assent, and so a lot of places, or 8, or whatever institution decides, but even that is a little bit, some children will understand, some children don't, and they still, we like to get them into having a say. But so for that reason, we have gone very far the other way in protecting those populations, so testing drugs and new therapies in adults who are fully capable and willing to consent, which is frustrating because trials take time and there is a threshold of determining safety in those, fully knowledgeable and consenting populations, that from a industry research protection perspective, we feel like we have to meet before we can move on to kids. That being said, I think we could be more aggressive using existing drugs that have some prospect of benefit with minimal risk to children that could go to trial sooner, which I think is why the lorazepam that I mentioned, which has been looked at in other gastrointestinal conditions in children, was probably able to progress to trial sooner. So I think there are going to be other things along those lines. But as of right now, that's really the only thing in the clinical trial ballgame. I know they're continuing to look at adding new variants and new mechanisms to vaccine armamentarium. But as demand has slowed down and our ability to, find infected in the population, that has slowed down the process a little bit as well. Which is good. We're glad that there are less cases of COVID, although we're now seeing a bit of a turn, so that could change in the next 6 months. But that I still think that prevention from getting the disease is the best way to not get the long-term impact. But getting a more efficacious vaccine is the goal. So those things are still in process. There's nothing immediately on the horizon. And that I've heard of that's like, oh, this is a game changer, we're just going to skip ahead and license this. So yeah, there are lots of things in the works. Other areas that go beyond what I know to be actively in the trial space are, I know many of you probably are sort of team clots followers. And so I think the microclot theory and use of combination anticoagulant medications is an area that should be started in clinical trials in kids. I know that they've been doing studies in adults internationally, and they've started to do some here. I think that's a good area for consideration, although a little bit higher risk than a lot of our medications, because obviously kids like to run around and play and fall. And when you're on anticoagulants, that's a bleeding risk. So it'll have to be done in a very thoughtful way with a lot of risk mitigation. And then I, personally hope that more I would love to see a scale down or an age down of things like Paxlovid, so that people under 12 can get a chance to try that. So I'm not sure where in the sort of clinical trial pathway that those studies are. Most drugs and vaccines have to have a pediatric testing plan. So they may be planning that at some point. But again, there's some risk and side effects of that, although I think ironically less so in the kids because there's less polypharmacy that's going on in the older population, which bed interactions is one of the biggest problems with Paxlovid. So.
All right.
Please interrupt me if I'm going on too long. I'm very long-winded.
No. I'm in the greater Boston area, so my son was tested for the study you referenced. So we tried to get the word out in New England because it's only in this area to see if we could get enough people. So let's see. We have another question. Do you see pediatric patients in your clinic with PANS, pediatric acute onset neuropsychiatric syndrome? If so, what are the treatment options?
So in our long COVID clinic, as of right now, we do not. I will say I've seen one or two patients that may have also met not criteria strictly, but have had unusual change in sort of their behavior following COVID, which doesn't mean like the strict OCD, anxiety-based symptoms that we see with pandas. We unfortunately do not have the resources to accept sort of all pandas patients at this point. That is ultimately a goal that we have for our clinic, is to evolve into a broader post, infectious illness group that we can take all comers. And I think that will help everybody with that. So we can have standardization and centralization of care. Right now, that's not something we've been able to do. I individually in my infectious diseases clinic have seen these kids over the years, but one here, one there. And I know it's really challenging. What I can say is that there have been a few studies that, have not shown that long-term antibiotics really give any benefit over not doing that. There have been other studies that have suggested that some degree of anti-inflammatory or NSAID medication with exacerbations may shorten those exacerbations or those flares. But I think there's still, like other worlds, there's so many more questions, so many bigger research trials that we need for a condition that's rare, but we see, any pediatric subspecialist or pediatrician at a tertiary care center is going to see these cases. So we need, more individuals to study.
All right. What are cutting edge diagnostic tests that families with long COVID kids should be asking for?
That's a little bit of a tricky subject. I think insurance is always a challenge. And getting the test in question linked with a diagnosis that insurance will cover is something that a lot of us have to do in this space. I will say, for example, at our clinic, we have a panel of sort of hypercoagulability and platelet function assessments that I use and we use as a surrogate for potential damage to the lining of the blood vessels, endothelial dysfunction, and potential risk or clotting. This is somewhat in place of having broader microclot testing, which there is a technique that Dr. Pretorius from South Africa has put in place, and that we have actually met with her about. But there's you have to have the equipment, you have to have the protocol, you have to have the licensing fees, you have to get the training. So there's a lot of steps to get that. And I think that's an area where I hope more clinics take that on, because once you get those things, it's a relatively, it's a point of care microscopic examination that may be relevant and helpful for, providing anticoagulation therapy in some patients. But I don't know that there's a lot of centers that are doing that, and even less so in the pediatric space. But, testing for microclots or testing for, coagulability is one area that I think is helpful to ask about. I think making sure that clinicians have considered other more well-defined diagnoses, or I guess I should say historical, infection-associated chronic illnesses. So things like MCAS, where there are actual hard and fast diagnostic criteria, not that they're perfect, but, that's been considered, and the serum tryptase has been considered, or, things along that line, that dysautonomic testing has been considered. And it's not just a tilt table test, but also a lean test. Or if you're in a place that has someone that's a little bit more specialized in dysautonomy, which is hard to find.
Yes.
Impossible to find.
Having walked this path for over a year with my son, finding people, and then, once you find them, getting in to see them, right? Like, it takes months and months and months. So
I think there needs a little off topic, but I think what's needed in this space in the long term is some sort of training program for physicians for dysautonomia. If it's like a fellowship or a sub fellowship or, you know, something, because it's an area that doesn't necessarily have ownership. Like some cardiologists do it, some neurologists do it, but it's a system-wide, body-wide thing, process that there's just not enough specialization or knowledge about. So, you know, I think that's a bigger area, but, you know, advocating for better medical education and, you know, specialist postgraduate training, I think is something that down the road will be helpful. Right now, it's not going to, you know, help people immediately, but, you know, thinking a few years from now, I myself have thought, you know, is there a certificate program or something I can do so that I can feel comfortable prescribing, you know, beta blockers and these other medications that typically are left to heart doctors because they affect the heart rate. But I think, yeah, that is the challenge. But some of those things like a lean test, like orthostatic vitals, can be done by anybody in clinic, anyone with a blood pressure cuff and a pulse ox, which all clinics have. So it's, you know, need for time and personnel, which is always a challenge, but the equipment, at least, and the procedure is not specialized. I think those are the biggest things. I think small fibroneuropathy biopsy can be helpful, but again, hard to come by. But that can be useful as that is a like an actual tissue diagnosis. So if you've got that, then meds are often justified, like IVIG and other infusions. Yeah, I think for now, that's kind of the best that I've seen in terms of evidence. I know people have used cytokine panels to kind of look at different markers. And I think that's a great question. I think it's still in the area of a research question. You know, we don't know what having an elevated IL-2 means exactly, in the setting of everything else that's going on in the world, in kids that get infections all the time and their immune systems. But I think if that's something we research and we have a drug that can specifically treat that, then that would be a great trial. So, you know, I think, you know, rheumatologists kind of lead that world. So getting more of those into the long COVID and in this infection sphere would be beneficial. And I think that has a lot of potential as well.
All right, thank you. Okay. You're talking a lot, so because you're the expert, it's Q&A with an expert, right? So based on what you see in your clinic, please explain what percentage of kids who have long COVID symptoms after their first infection, but get back up or seem to be better, then go on to have more debilitating symptoms at a second infection.
I have not had the chance to look specifically at our numbers on this, although we have that information. I would say, and it's evolved over time. So, you know, we have a lot of patients that have presented later, you know, now with multiple infections than they did initially. But I would say probably at least half, you know, had it after their first infection, and particularly in the early stages, and then half had it after second or third, even COVID infection. So it's certainly something that, for whatever reason, you could get by the first time in some cases, be asymptomatic, and then, you know, happens the second time, which is fascinating. And I would love to know why.
Yeah.
So would we all, right?
All right. Let's see. Another question from our community. Based on your observations in your clinic, do you see cardiovascular impacts on children with long COVID with no history or previous history or prior history of cardiovascular issues? If so, can you describe?
Far and away, and this is only loosely cardiovascular, but I think dysautonomia and issues with tachycardia or orthostatic intolerance, which is vascular, not so much cardio, but certainly vascular. I will say that a good percentage, at least a third of our patients, or a quarter maybe, get seen by cardiology at some point in their course, and thankfully never have any structural heart problems or EKG abnormalities or arrhythmias. Most go on a Holter monitor and don't have any abnormalities on there despite having symptoms, which is good, but it doesn't mean they're not having those symptoms. It just means they're not electrical or structural. But I think the vascular issue, and the regulation of changes in blood vessel tension and blood pressure and heart rate, all of those things are definitely prominent. So the POTS and dysautonomia spectrum is pretty common.
All right. Another question. My son is 5. He had COVID 2.5 years ago and struggles with undiagnosed allergies that trigger severe phlegm episodes, gagging, vomiting, phlegm at night, and ADHD, OCD, anxiety, all directly after having COVID. Is this something you see in your clinic? If so, what would you share with a parent?
I cannot say that this is something I've seen much of in our clinic. It does sound concerned with a new diagnosis of like OCD. I would be concerned about PANS. So I think there's that aspect to look into it. I'm not sure what to make of the recurrent sort of phlegm attacks, allergies versus multiple infections. I mean, like I always say, kids, it's on average get 8 to 10 viral infections per year, young children. So but yeah, not something that I've seen a lot of in our clinic.
Okay. All right. In your opinion, why do we see clinical trials for long COVID treatments for adults, but not children at this time? And you did touch upon this earlier. So I don't know if you want to go, we have a follow-up to that, if you want to go right to the follow-up, because I sort of covered that already. Why does it seem like pediatricians are more cautious treating symptoms with long COVID kids versus adults with long COVID?
A lot of different things. I think the risk, it all comes down to the risk benefit ratio. And that's how, good clinicians think about things. And, most of us, as our life goes forward, it's how we evaluate, major decisions in our day-to-day livelihoods. Is the risk that I'm going to take or the cost worth the benefit I'm going to get from this? For children, there are a lot more unknowns in that space because we don't have as much clinical data, for the reasons I mentioned before. We don't have, FDA approval of a lot of drugs. So on one hand, pediatricians are actually pretty comfortable giving things off label. But when they're dealing with something that's novel and off label, it's a little bit more anxiety inducing. And kids in general are very healthy at baseline. So the concern about inducing some sort of side effect or anything that could even remotely have long-term potential of harm, that's a bigger risk than it might be in the adult population. And somebody that already has, X, Y, and Z conditions, there's more likely benefit there than in the other. So all that being said, with conditions like long COVID, there is, I think, more potential for benefit. But in many of these, drugs that we're talking about, the risk might be unknown. And so there's a lot more caution. I do think that there's probably more space for some shared decision making and discussion around those topics, which kind of gets back to my being willing to acknowledge that you don't know, but having a frank conversation with families. But I think a lot of physicians feel, and some families, honestly, that's passing the buck, and that there's this, paternalistic sort of tradition in medicine where the doctor should know everything and should make the decision for the family, and it's yes or no, binary. But I think I think we should be moving a little bit more flexibly to try new things. But be aware that like the family has to agree that it is worth the risk, and they have to be well educated, or at least as much as we can of the risks, so that we all feel comfortable and feel like it is worth it. Because what you don't want to have is, clinician risk benefit is here, family risk benefit is here, and something happens and you weren't on the same page. That, it's a bad outcome happens and the family comes back saying, I didn't know that was a possibility. That's not what you want. So I think it's just, again, that vulnerable population and a slightly different calculus makes it more challenging. But I think we could be a little bit more involved in risk taking with families that in particular have kids that are out of school for 6 months or a year because they're so disabled from their symptoms. So
yeah. I've walked that path too with my son, so I understand.
Next, why I'm pretty sure that doctors will not be completely replaced by AIs, because it's not that easy.
No,
for better or worse.
You can, yes, your breadth of experience and depth is we need people like you. So, what would you tell someone who has a newly diagnosed child with long COVID?
So kind of going back to the tips for general pediatricians, I guess, in a way. So, I think getting a good sense of what's going on with them. So there are inventories out there, or just doing a good review of systems and keeping track of that information. And then screening for things that could cause more harm. So postexertional symptom exacerbation, if there are any red flag cardiac symptoms, making sure that those get checked out. And those are, there are lists and literature on that, but essentially things like chest pain with exercise, chest pain with lying down, chest pain that radiates. There are chest pains that are not concerning for cardiac disease. And so working with your pediatrician to kind of determine that, because we don't want to send somebody that has an arrhythmia into, increasing physical activity. Same thing with post-exertional symptom exacerbation. I think even before being fully diagnosed with long COVID, I would emphasize the need for rest, both sort of cognitive and physical in the early phases, and then developing a pacing, your own sort of pacing plan for how you're going to get back into things, which I know is hard when you're involved in activities and you want to get back to that. But I think that's something that needs to be established. And I know there are good resources out there. Long COVID Kids has good resources on, pacing and how to think about it. Long COVID Physio has good resources as well. And so that would be, coming up with all of those things are things you can do yourself or with your general pediatrician without having a whole bunch of other tests in major things, and will at least help prevent harm, and will slowly start the recovery process in a safer way.
Yeah. And my son works with a cognitive SLP in terms of, how to manage his brain fog. He's 17 and a half, so it's a little bit different than a little child. But still, it's so important to pace and rest and take frequent breaks. So
everything that is like not the ideal in our culture today, right? Yeah.
Right. Yeah. But we do what we can.
Yeah. No, we need to change it. That's it's okay. It's okay to rest. It's okay. Rest to recover. it's something we need.
Yeah. Parents too.
Absolutely. That's a whole nother, whole nother thing. But yes, that's
yeah. And Megan just posted our pacing guide, so that's
beautiful.
great.
I love it. Thank you, Megan.
All right. What, in your opinion, do long COVID kids struggle with the most?
I think, as I said, fatigue, in terms of like a symptom. And then closely behind that, the cognitive dysfunction. So the brain fog, if you will, or issues with memory, with concentration. Those are kind of the most, I think, debilitating and maybe scariest in some ways, because you can't figure out your own mind. Anxiety as well about those symptoms. are kind of the things I've seen the most of. Now, from a non-symptom standpoint, somebody in the chat mentioned, getting screened somewhere that will take it seriously. So I think finding a pediatrician or family medicine doctor that accepts that this is a thing and that long COVID is a thing and that kids aren't going to necessarily bounce back from every viral infection is a struggle that has maybe slowly gotten better over the last year, but especially early on in our clinic, like I'm sure I don't have to tell you, going from doctor to doctor to doctor to find somebody that even has an inkling of what's happening and can put a name to your symptoms and validate and believe and start working in the right direction is a challenge. And even more so for families, if you have multiple kids and working through that whole process. So I think that's just even harder in the pediatric population than it is for adults.
Yeah. All right. What do you think medical professionals could do to alleviate some of the struggles? And I know you've touched on some of this already.
Yeah. I mean, I think it's getting the education out there. It's getting that piece, that humility piece, that understanding that we don't understand, but we're going to help. I think there are, maybe novel methods that some health systems use, like, email communication, portal messaging, telephone, just quick check-ins that could be done about symptoms that don't necessarily require a full visit, but, how's your fatigue? Is it any better than it was last week? No? Okay, let's do this. And all of that is, needs to be supported for that person doing it. So, like, let's not even talk about what the medical establishment can do for providers to help patients, because that is a big challenge too, because all of these conditions are very, very complex and time consuming, and not just time consuming, but also mentally challenging for everybody involved. So, there's just not enough resources. But I think it's a lot of being open-minded, a lot of being supportive, validating, yeah, I mean, I think maybe I should leave it at that. I do think that we could do better communicating to each other. I think those of us that do have experience should find a way to guide others in the community, but getting that word out there, that knowledge, and again, the time to do that is a challenge. But I think we could build networks and, build like a physician consult service that might help just say, yeah, you should screen this kid, or yeah, this is what's happening. Oh yeah, pacing would be good. Those sort of little things until we get more establishment in medical education of this sort of area. And being willing to have, as I mentioned too, those conversations, those risk benefit, and being willing to try some things that maybe aren't well established with families that are really struggling.
Yeah. It's interesting because somebody just posted something under Q&A, which was, you kind of just touched upon.
Oh my gosh, yeah. I'm so sorry to hear that. Should I read it, or?
Yeah. Do you want me to read it, or
yeah? Why don't you read it?
Why don't I read it so you can have a little break and drink some water? All right. What initiatives are being made to educate community pediatricians about long COVID in children? Many of my children's doctors, therapists keep saying my children are the only ones they know of with long COVID, and talking about deconditioning, anxiety, and the need for graded exercise therapy, PT for fatigue. They do not seem to be listening to me and my children about how these measures have not been helpful.
Yeah. So I know that the AAP has a interim guidance, like document website that I've been heavily involved in helping with, although it's still pretty broad, but does touch on some of these issues. I know that they are working on, getting it into some forms of curriculum. So for example, there's a annual pediatric infectious diseases course that the AAP offers for general pediatricians. And this year, one of their lectures is about long COVID. So that's obviously not going to get to everybody in the general, but it's a step in the right direction. So I think continuing to develop modules and speak on the local level is kind of where we are now. But I think getting it more broadly out there is important because you're right. It is rare enough, again, that in one community, in one city, there may only be one kid with long COVID. But that isn't an excuse to not know about it. There are other conditions that are very rare, and we've just had 50 years to hear about them in medical school, and it sticks in your head and you're like, oh, I remember that one thing from that textbook 20 years ago. So it's I think there's modules and other things that even local professional societies need to get out there, but we're starting to do things through the AAP. So
All right.
And I'm giving that PEDS ID course lecture, so that's why I know about it.
Okay, and maybe we can listen to it as well, because we like listening to courses. All right, let me see. I think we're almost at the end of the questions we had in advance. And again, a lot of these we've touched upon. And one of the other questions was really about, what do families with long COVID kids struggle with the most? In your opinion, what do you see?
Yeah. I mean, I kind of touched a little. I think the struggle with the uncertainty, I don't want to say gaslighting. It's not always gaslighting. Sometimes it's gaslighting. Sometimes it's unintentional and just the lack of expertise and ignorance to a degree, or the challenge of a rare situation and inexperienced clinician population, and the burden that takes on the families seeking for help rather than the caregiver or the pediatrician or have you, is probably the biggest thing I see. Also the lived experience of having a kid, especially if they're affected enough to not be able to go to school. If my parents work, they can't do that. And so there's definitely a lot of need for FMLA and other support for that family. And then, the more emotional struggles of seeing your previously usually very healthy, very high achieving child be a shadow of their former selves, and what that does to you with your mom's heart. And I think that's why I'm glad an organization like this exists. And I hope that people in it are using it to talk to each other, as a support group, because that is a hard thing to see. And we know that with other chronic illnesses, cancer, other things like that is a challenge. But we don't have to suffer alone. So talking to other parents. So there's multiple levels in which families are impacted, for sure.
Yeah. And it also comes down to resources and time, right?
Mm-hmm, mm-hmm.
So, is there anything else that you haven't touched upon that you think that medical professionals could do to help families going through this?
That's a really great question. I think, I think I've kind of touched on most of those areas, and a lot of it does come down to time and resources. I think it would be great if more community pediatricians could have sort of a post-COVID screening clinic or a post-COVID day, or something that they can regularly check in on their kids to make sure they're not having these problems, particularly those in otherwise sort of what's the word I'm looking for? Like disadvantaged communities, minority communities, places where we're seeing, unfortunately, seeing a disproportional representation of those with more education, those with higher socioeconomic status coming to these long COVID clinics, even though we know that that's not who COVID affected the worst. So, I think concerns about those communities getting the education of the physicians in those communities or PAs, NPs, and doing more of that screening with those folks, I think would be really important. But again, it's a level and then a level. I think there's room for community organizations and maybe the schools also to kind of take a role in screening for this. I know a lot of schools do partner with local physicians or, I would say a school nurse, but I know that like one school nurse has to cover like 7 schools. So that's not always the best. But like that's another area because a lot of these kids will be struggling and their frequent absences may be the first sort of sign that something's going on. So that's another area of partnership that could be further bolstered between medical professionals and the schools and the families.
All right. Well, we had you talk for a long time. I am looking at the Q&A and chat.
I think I saw a couple questions in the chat.
Yeah, that we haven't touched upon. We still have a couple minutes.
Okay.
So if there's anything, let's see. How are you differentiating a continuation of symptoms from organ damage or other issues that present later, long COVID versus post-COVID?
Yeah. So, I think some long COVID patients have a little bit of both. But I think in kids, there generally seems to be less of the direct organ damage from acute infection. And I say that to mean that, most kids are generally do pretty well with their acute COVID. They maybe have, some headaches, some are completely asymptomatic, but we don't see as much of the severe COVID respiratory, ARDS type of situation that we saw in the adult population, or needing to be hospitalized. Those, to me, are the things that would make me think of direct, organ damage and persistent effects. Although you can make an argument, a good one, that any symptom that starts with the acute infection and then continues would also be evidence of direct infection and damage from that initial infection or the immune response, I guess, from that infection. So, I think it's a little bit academic because I think some of it is, it's a continuum of processes and we need to figure out how to stop at multiple areas. But it's not a perfect science. But I would say kids that have symptoms that completely recover and then have symptoms that start up 2-4 weeks later, would fit to me with a not continuum of the acute infection, but a later developing sequelae of a long COVID, but both fall into that same disease definition. Let's see. Yeah. So I see there's a question where to go to get this screen. So I know that's a challenge. I think there's not, maybe there's a listing of long COVID. I don't want that to be the case though. I don't want this to be only a niche diagnosis that only certain people believe in and can manage. I want to get community pediatricians involved and understanding and, the specialty clinics like ours are around. There's, I think, only about a dozen, so there's not many, but they are around. They are willing to work with pediatricians, at least as a start. And so, going to them with this list of here are resources. Can you, we talked to one of these doctors, can we start there? Might be a good way to do it, but that is a challenge. And I'm sorry that so many have experienced that inability to find someone to take them seriously. And then I think I see a question about repeat infections, metformin for 10 and older, Paxlovid for 12 and older. So absolutely Paxlovid for 12 and older. If your kid's 12 and they get reinfected, absolutely try and get it. I mean, Paxlovid is underutilized. And I think there was this initial like, oh my God, there's all these like criteria to give it. And it's so, sequestered. It's pretty broadly available now. And like I said before, kids don't take a lot of the medicines that interact with Paxlovid. So if they fit that, risk factor category, which includes having asthma, high risk, then definitely pursuing that. If they don't necessarily fall into that high risk category, as it stands currently, I think a conversation with your doctor about long COVID being a high risk condition, I would consider it a high risk condition and would think that they should receive Paxlovid. Metformin, I think, is an interesting idea as well. I don't know as much about the studies. I've seen, a couple, especially in the adult population, of the benefit there. So I think it's worth discussing. I know that it gives people a lot of abdominal pain and diarrhea and kind of nasty GI symptoms, but it might be worth considering in the right situation.
And we had one more come in under the wire. Somebody wanted to know where you were located, and you're in Washington, D.C. at Children's National, but what advice do you have for patients going through this currently?
It's tough. I am sorry that you're going through this. I think biggest things are, things that you can do at home by referencing, the links that we've had here, things through long COVID families, long COVID kids. So starting pacing, backing off on activities as much as you can. And then trying to find someone with knowledge about this disease that can kind of help you manage, help walk through it. It could be a generalist, even just someone with an open mind that is willing to kind of take you through it. It might have to be a specialist at a long COVID clinic, but it is a challenge, and but there are resources like this to help you find those tools and get in touch with people that maybe have had success finding those tools too. I think the other piece I would say is that I mentioned earlier that kids are resilient, and that's one of the challenges, especially in the early phases of this. But in my experience and in what's been published in the literature, most kids do eventually get better. And that's not to say they go back 100% to their baseline. But they do. I think the study I was thinking of that was done in Italy said that by 12 months, maybe 10% of those with long COVID still had ongoing symptoms, and by 18 months, 5%. So there were some that still were not better at all at that point, but that most had experienced some improvement, and we've seen that in our clinic too. So again, not that you're going to be back to running marathons if that's what you were doing pre-COVID by 2 years later, but may be able to go for a jog for a mile or two. So definitely there is some improvement. There is some hope. Not all is lost. And the hard part is that in the lifespan of a child, 1 year out of 17 is much more impactful than 1 year out of 50 for an adult. So you are missing more, even if it is just a temporary or something that will get better over time. So it is more impactful. But I think that's a reason to have hope that things will improve, especially if you're, being active and thinking about it and trying to manage energy and find the resources you need. So hopefully that, is not making light of anyone's situation here, but I will say in my experience, again, there's generally some reason to believe that these kids will be functioning adults and things will be better. It will get better, as they say.
All right. Thank you so much, Dr. Yonts. We covered so many things. We got to all the questions pretty much.